I'm looking forward to talking with you all about something that's near and dear to me. You can see in the title of the talk, there's a little bit of health policy, so talking about universal health care and also the personalized nature and some of the wonderful work that has happened here at Stanford in primary care transformation. So I'm going to be reviewing and showcasing that work, and a number of the leaders who are involved in that are here today. So I'm so thrilled. It's such an honor to be back. I'm so glad that I'm back here at Grand Rounds, not as chief of staff, talking about how we're doing with testing and how we're doing with all of the vaccinations back in the pandemic. It's good to be back talking about some of this other stuff and focus on it. I wanted to also just highlight that this is I'm not sure why it's not advancing here. There we go. It is Black History Month last week, and I just wanted to put some of the photographs of the folks who have inspired me over the years. You can see folks like Octavia Butler, Dr. Martin Luther King Jr., James Baldwin, W.E.B. Du Bois, Ta-Nehisi Coates, Audre Lorde, Bell Hooks, just these incredible figures that throughout my life have inspired me. And then prominently displayed is my mother, who lived by a motto that I realize now is actually from the Association of Women of Color from a long time ago, lifting as we climb. My mother was one of the first Black female mathematicians in the country and later was a university president. So, all right, so let's talk about primary care. This is a slide that I used a lot back in 2015 when I started to look at care transformation. And at the time, we just thought it was so absurd to think that someone would be using their phone for their medical care. But I think all of us can relate to the fact that we do. And we now access our doctors all the time and on our apps and our phone. And in fact, you might even want to be doing that during this lecture. So if you look down at your phone, I'll just assume that you're talking to your doctor and note it's all good. So this is just some data from our very own Tate Shenefeld, who started to look at this important issue of physician burnout really early on, even before the pandemic. And these are the data over the years. I also, given that I am a family medicine chair, I pay attention to the family medicine data, which could be a proxy. It's pretty close to the general internal medicine data, where over the years we've seen that in family medicine, the odds ratio of having a significant burnout is about 1.57 compared to the average. And we know that as physicians, we have a lot of resilience. So it's not a resiliency deficit. And even among, we're talking about Black History Month, even among, racial minorities groups, there's even more resilience, typically, we're seeing in the data. However, underrepresented in medicine, faculty may experience even more exhaustion and burnout related to systemic racism. And so this is not a resiliency issue. This is really has to do with the nature of the job. And you can see that the family medicine data I have entered in blue on top of the other lines there, looking at physicians compared to the general population of workers. So the primary care pipeline, I think we're familiar with this. It's shrinking. I think a lot of us have struggled with getting a primary care provider. I know I have for my family. Most residents are leaving the field within 3 to 5 years, and nearly 90% of internal medicine residents subspecialize or become hospitalists. Federal funding is scarce and it's becoming worse. And only 0.2% of NIH funds are dedicated to primary care research. So it's really hard for us in academia to recruit and retain our primary care oriented scholars, and this problem is going to continue to get worse. And I'm just heartened by the progress and the advancements related to the ACE program that is within the General Internal Medicine residency program, and really supporting that, that primary care, giving those exposures to retain some of these folks. But these are the numbers, and you can see the trend over the years. Very few primary care residents remain in the field long term. Nearly 90%, as I mentioned, go on to subspecialize, and a growing number of pediatric residents are also subspecializing. When we exclude the hospital-based physicians, only 21% ultimately practice outpatient primary care. And so that's why these foundational programs like ACE are so important in ensuring that we have a workforce for all of us as we get older as well. So family medicine, again, as a department chair, I'm tracking this. That shows stronger retention in outpatient medicine, which is a positive sign given the ongoing expansion efforts that are happening within Stanford, with Grace Yu and David Quellen, the program directors of the family medicine residency programs that are happening. Warren Newton, who is the president and CEO of the American Board of Family Medicine, presented these data recently, and those red arrows are showing the trends. And so we just have seen a dramatic decline over the years in the percentage of medical students who have indicated an interest in family medicine and primary care when they enter medical school. That used to be our strength, right? Like, it used to be that kids would be inspired by their own pediatrician or their family physician, or they wanted to be the doc for their entire community. And then our job was to retain them during medical school. But actually, what's happened is that we're seeing a dramatic decline in those who are even indicating an interest when they are entering medical school. So the focus for those of us who have been looking at this has been around maintaining the interest. So it's away from maintaining the interest only, but also to recruiting people in and trying to give them early clinical exposures. And one program that I'm inspired by here at Stanford that comes to mind is the Patient and Family Engaged Medical Education Program led by Erica Schillinger. So a quarter of primary care physicians are over the age of 65 and are set to retire within the next 5 to 7 years. And during the timeframe of 2021 and 2022, 16,000 primary care physicians left the workforce, contributing to a 10% decline over a 10-year span. And those of us are facing demoralization, which I mentioned, just overwhelming administrative burdens, a loss of agency, and a system that is prioritizing, from some perspectives, profit over patients. The primary care physician wait time is now increasing at an unprecedented level. And often, actually, and I've worked here at Stanford, and now I'm over at UCSF, and actually, our biggest advocates are the subspecialists because they need their patients to be seen by a primary care provider. And so it's actually been, great to build community and a coalition around this. So I was in clinic yesterday, and actually it was relatively smooth. I did have 2 prior authorization appeals to make and get on the phone, and I think the primary care folks could actually relate to that, and so that's why this is so resonates with me. Because these Ozempics of the world, the GLP-1 agonists, are causing GLP-1 agony for a lot of us, and so this is a contributor. It's a system. So as noted in this Commonwealth Fund report, patient complexity has doubled since 2000. So PCPs are juggling a lot of complexity and care coordination. Patients who are impaneled by primary care are seeing twice as many physicians in the last 20 years. And while most adults in similar 10 countries have regular doctors, the US, Sweden, and Canada report the lowest rates, with US adults least likely to have a long-standing primary care relationship. The per capita number of PCPs is declining, affecting everyone. So I just wanted to just do a rough poll with the folks here, and I know we have some folks online, who has had any difficulty getting a primary care physician, or for yourself or for a loved one, actually the majority here. And this is important from a lot of reasons, in addition to just quality of care. So Sanjay Basu, when he was here at Stanford, did a study and published this and found that every 10 additional PCPs per 100,000 people increased life expectancy by 51.2 days compared to 19.2 days for specialists. More PCPs also reduced cardiovascular, cancer, and respiratory mortality by 1%, with similar benefits across geographic and individual confounders analyses. And he used several instrumental variable regressions to really look at the density of PCP and how that affects life expectancy. So really important work that we often point to. So here's a timeline of the public healthcare system, and in the United States, it's a very truncated timeline here. As we all know, on July 30th, 1965, President Lyndon B. Johnson signed into law the bill that led to Medicare and Medicaid. In '93, in response to a measles epidemic, the Children's Health Insurance Program, or CHIP, was established to expand coverage for children. And the Affordable Care Act in 2010 expanded coverage to 93.5 million Americans in ACO arrangements, which incentivizes healthcare providers to meet more specific performance measures and develop innovative approaches to care. Medicare Advantage is outstripping traditional Medicare, which I think we're all familiar with. And then looking ahead in 2026, this is the focus of my talk, the future of healthcare may be shaped by universal personalized care driven by AI and collaborative teams. We often point to Medicare being the first proposed national health insurance program. However, the timeline could be traced back as far as 1792, when Alexander Hamilton advocated for a government-funded healthcare system for seamen. And here are some archival records showing Alexander Hamilton advocating for that healthcare plan, understanding the importance of a national healthcare for our workforce and our nation's economy. So the award-winning physician writer and Stanford faculty Alana Yurkowitz highlights in her book Fragmented how systemic cracks in healthcare waste time, energy, and lives, and offers and solutions for improvement. And she references the Stanford Coordinated Care Program that was launched in 2011 to support patients with complex chronic conditions. And this slide was made by my dear friend and colleague, Alan Glasseroff, who was the founding director of that program. And it shows how, when effectively done, coordinated care can evolve from the cup runneth over to a more streamlined, impactful model where we're sharing the care across partners. And Chris Sensky published Advanced Care, the model for the Advanced Care team, which would include at minimum the medical assistant, registered nurse, the physician, advanced practice providers, care coordinators, population health navigators, clinical pharmacists, social workers, and behavioral health specialists. And in 2014, Song Chang recruited a team to design this approach, not only for complex patients, but also for general primary care patients in clinics. And to develop this model, Primary Care 2.0, we visited 11 leading organizations like CareMore, Iora Health, and Geisinger, and Health System to learn best practices. And this design informed by consumer research, now serves as a model for many of the primary care clinics here at Stanford. I'm glad to hear that they're sustained. Each team is centered on the patient, and you can see that there's a physician and an advanced practice provider, medical assistant, and support from behavioral health specialists, a nurse case manager, pharmacist, and nutritionist with connections to specialist community resources and data analytics. And Marcy Levine should really be credited for piloting this first at the Santa Clara Clinic. Here are some of the outcomes. So one is the team development score, which showed higher scores in the primary care 2.0 clinic during the 24-month evaluation. And while there was a trend towards reduced burnout after 15 months of implementation, budget cuts eventually led to changes in the care model impacting these results. And just wanted to shout out to Marcy Winget, Katie Brown-Johnson, Jonathan Shaw for this work, in addition to Timothy Morrison and Heather Filipowicz, who were key partners in implementation. And the data for the, I don't think I can show it, but it's up in the upper left-hand corner around burnout. So this is particularly important, this focus on teams, because a review of studies related to diversity in healthcare showed positive associations between diversity, equality, and financial performance. And patients generally fare better when cared for more diverse teams. And it's all about trust. And so having a diverse care team can build that trust and that team culture. And we were looking definitely at this as well and published an article on racial bias and how that affects the team and team-based primary care. Here are a series of articles defining the role of the advanced practice provider in primary care-based model. This conversation is very topical today. I know that healthcare systems were still wanting to achieve a more and more optimized inclusion of the advanced practice provider. And this is work that was led by Vicki Tippett, Claire Kuriokos, and Dale Beatty here at Stanford. Were also part of some of these publications as well. And so Heather Filipowicz, Tim Morrison, and other team members evaluated the role of integrated behavioral health in primary care, which includes incorporating mental health services into primary care settings, creating a more holistic approach to care. And this model fosters collaboration between primary care providers and behavioral health specialists, improving access to care, early intervention, and treatment for both physical and mental conditions. We also looked at, reflected on the implementation science methods. So there was a development of the lightning report, which you can imagine working with these implementation science scholars as an operational leader and getting real-time feedback on what is working, what's not working, and then making those changes during the implementation was incredibly helpful. So there was a publication on this model, the Stanford Lightning Report, and then also how we applied the Consolidated Framework for Implementation Research, or CFIR, to evaluate our care transformation efforts. This provided a structured approach to assess the key factors that influence the success and identify areas of improvement so we could act in real time. So we were encouraged by the role of teams in driving improvements in primary care, and very excited about this movement towards standardizing and recognizing key factors, other key factors in healthcare, such as social drivers of health. This aligns really well with the value-based care movement. And so we saw this as a potential to leverage these advancements that were happening in the environment in genetic testing and expand care beyond the clinic walls to include new technological channels as a next step. So Dean Miner and Priya Singh played a key role in guiding and supporting our expansion of primary care 2.0 into precision health implementation. And this human-wide pilot, is what it was called, enrolled diverse group of patients for wellness assessments focused on social drivers of health, identification of their patient-related goals, remote patient monitoring, genomics, pharmacogenomics, which offered a holistic approach that empowered our primary care team to tailor care to each of the patient's unique needs. And we're excited by the role of technology that allowed us to extend our care beyond the clinic walls. And we were able to include staff and faculty in the design of this. However, we had an envisioned stronger partnership with the community in this pilot. And I would say that that aspect of it wasn't fully developed. And that was a key shortcoming to this 6-month pilot. And I'm going to talk to you a little bit about human-wide. So the implementation of human-wide demonstrated significant reach and impact in its pilot of 50 patients. Participation rates were high across all the key components. So you can see some of the components here. 94% of patients underwent pharmacogenomic testing, 80% completed social drivers of health assessment, 72% received genetic testing, and 64% engaged in the remote patient monitoring. Brilliant collaborators, including Latha Palaniappan and Russ Altman, contributed to the pilot, as well as Steve Ash. Notably, every patient in the pilot benefited somehow clinically from at least one component of the program. And I would say a highlight was the pharmacogenomics role. There are several testimonials that are still available on a human-wide website, which calls 100 hours of footage that was documented for this rollout. So I'm going to talk a little bit about the pharmacogenomics testing that allowed healthcare teams to personalize medication regimens based on drug-gene interactions. And you can see here, 28% had clinically significant findings affecting chronic medications, particularly statins, SSRIs, and PPIs. And 16 patients of 23 reported, of the 23 who went through pharmacogenomics, 16 patients reported 23 past or current medication side effects. That's how I want to say it. With 39% of those 23 linked to their documented metabolizer status. And then in pharmacogenomics, I'm just going to talk a little bit about what preemptive and reactive mutations are. So preemptive mutations are identified before prescribing medications, guiding treatment decisions. Reactive mutations are detected after a patient begins their treatment, often due to adverse effects or lack of efficacy, and that these mutations then inform adjustments. And in our pilot, we observed a high percentage of preemptive mutations and very commonly prescribed medications that you can see here, including psychiatric drugs and statins. So imagine that you have a patient who oftentimes we're coming up with the antidepressant that we think will help this patient. Imagine being informed based on their genetic background and getting to that medication earlier that's going to be effective. And this is significant because many studies show that the annual savings from pharmacogenomics testing can range, you can see the range here, about $1,400 to $3,000 per patient. The benefits include reduced prescription waste, shorter time to effective treatment, but the greatest impact for patients with psychiatric conditions. Pharmacogenomics testing has been linked to fewer hospitalizations and fewer emergency department visits. We also evaluated the remote patient monitoring component, where we saw 64% uptake, and we used this structured interview guide. You can see the structure in the questions here. And you can see the range of comments that reflect the strengths and the weaknesses of implementation. So you can see comments from patients who talked about the relationship between, sending these data in and then how they were then activated and engaged. And then a specialist said, just because we were able to access how things are at home, we could see what their blood pressure looks like at home versus in the clinic. It saves a lot of time when you're meeting with patients because you have all that information ahead of time. And then a primary care provider said, I think that the key thing is that it builds the relationship with our patients. If I had If I have to see you in 3 months, you're not going to think about doing your blood pressure, pushing a little more of how are you doing, what's going on, just trying to understand that. I think our goal was to try to be more engaged in the lives of our patients outside of the walls of the clinic. But I wanted to highlight this important comment. It does put a lot of the added burden back on the primary care provider to look at all of these streams of data. I'm getting 5 to 10 trackers, tracking notices every single day, and then that's just a lot of information. And I'm trying to look at everything, but it's just too much. So yeah, it was a important implementation, but maybe too much for a PCP to handle. But now we have the opportunity of AI, and so that's where I'm seeing a window into personalization at scale. And this involves risk stratifying patients to tailor the care. And this is really our opportunity to take that Stanford coordinated care model and apply it in a mass customized way. So back I mentioned in 2018, there were these videos that were produced on the Human-Wide Project, compiling hundreds of hours of footage. But just last April, I was listening to an advisory board podcast, and they were discussing how there's this unprecedented advancement and an opportunity to customize patient care, and that will lead to transformation in the care model and the financial model. And they referred to this era of bespoke care driven by AI and Moore's law, which highlights the rapid increase in computing power. And so it was just like, oh, wait, like a lot of this stuff maybe, is coming back. So maybe this is the time for a better customization of care powered by this unprecedented volume of data, the social drivers of health, genetics, wearables, and the EHR data, and streaming in to guide decisions. And so I look forward to hearing your thoughts on this if this is the time. So many when we were implementing, I'm not sure if people have heard of Forward Health. When we were implementing this, Forward Health is a tech-driven primary care startup that aimed to revolutionize healthcare by offering personalized care with a focus on prevention, leveraging AI and data. So sounding very familiar. It was founded in 2016, and it expanded rapidly, opening multiple clinics across the US. However, the company faced significant challenges, including high operational costs, difficulty scaling while maintaining success, and they really struggled to achieve profitability. So this led to an abrupt closure in 2023. Maybe you heard about this in the news. And now if you flip through some of Forward's websites, they have all the same message. Much like the healthcare system, this link is broken. And so let's talk about the healthcare system. We're not going to be successful unless we talk about that. So this is all review for this group, but the universal aspect of this discussion has to do with the healthcare system. Could the US afford a system of free, basic, automatic enrollment healthcare? And the answer is yes, absolutely, because if you look at the percentage of GDP that we contribute to healthcare, half of it goes currently to the public health system and half goes to private care. And interestingly, if you look at the many European counterparts, they spend around 9% of their GDP on a public healthcare system. So it's possible because we're close to that already. So we could afford this theoretically. But I wanted to ask the group, my colleague and predecessor, Department Chair of Family and Community Medicine at UCSF, Kevin Grumbach, posed an insightful question and recently published this in a study that I'd like to ask you. So how much of the total healthcare spend is allocated to primary care currently? Kevin knows. 0.25. Yes. Here's the answer. So primary care accounts for, 30, depending on how you define primary care, 35 to 50% of healthcare visits, but only receives 5% of the expenditures. And in his study, the average guess was 10 times 5%, 50%. Most people thought 50% of healthcare expenditure was being spent on primary care, but it's actually 5%. We also have the widest gap in the wages between generalists and specialists compared to other OECD nations. US life expectancy is 3 times below the OECD average, with the highest infant mortality rate in most adults with multiple chronic conditions. Racial and ethnic health disparities remain deeply entrenched. And I just love this quote from Walter Cronkite: "America's healthcare system is neither a healthy, caring, nor a system." So I think we're familiar with the frustrations around the healthcare system among Americans. Kaiser Family Foundation, health policy think tank, in the preceding year, 18% were refused care they thought they should be receiving. 27% had insurers pay out less than expected, and 2/5 say that they had to go without health care because of insurance limitations. In recent years, denial rates have been soaring, while the insurers have adopted new tactics, including the use of AI to make insurance coverage decisions. So lot of challenges here. There was a report that was relatively recently published in 2021 by the National Academies of Science, Engineering, and Medicine on primary care, touting that primary care could be viewed as a common good. And this builds on decades of research emphasizing primary care's critical role in public health. It follows an earlier landmark report, including the Institute of Medicine 1996 report, Primary Care, America's Health in a New Era. And it defines primary care's essential functions in the economy. And this report was commissioned to address ongoing underinvestment, workforce challenges, and health inequities in the United States. And it reaffirms that robust primary care improves health outcomes, reduces costs, and promotes equity, and calling for systemic reforms to strengthen and sustain primary care nationwide. And these are the 5 objectives for achieving high quality primary care, according to this report. And both Kevin and I have, in separate journals, advocated for primary care to be recognized as a common good, like libraries, like fire departments, and other essential services in society. So this is an uphill battle. And fighting for healthcare reform often feels like pushing a boulder uphill. I have to say, when I assumed Kevin Grumbach's office, a lot of the textbooks that he was writing back in the care management days, you could pick up today, and they're relevant. So the fight continues. But together, we can make progress, and even Sisyphus needs a vacation and needs to, just get charged up for this. Because really, this is about, just the economy. Economists have argued that universal basic insurance is essential for ensuring equitable access to healthcare, reducing those administrative costs, promoting better health outcomes for all. Several states have implemented initiatives to increase the proportion of healthcare spend allocated to primary care, California being included in that. And this is aiming to enhance care quality and cost controls. CMS has implemented a series of payment models aimed at increasing primary care investments. And of course, we have to think about the larger context here. Just last night, we had the House that narrowly passed a budget resolution that will require a budget cut of $880 billion from our healthcare spend, resulting likely in an 11% reduction in Medicaid over the next decade. So this is these are the forces. But I did want to just highlight that following RFK Jr.'s appointment as Secretary of Health and Human Services, this Make America Healthy Again Commission website was launched. And when you read the website, it's sounding a lot, there's a lot there about prevention and chronic disease management. And the commission promotes these policies around creating access to care and the benefit of early intervention. So, as we start thinking about the goal to reduce long-term health costs and improving, public population health outcomes, primary care could play a pivotal role. So we shall see. And with that, I am going to end. And it's been, really, just a true pleasure to spend time with you and be back here with you all. It's a real honor. And I just am excited to see the work that is being continued here with such passionate individuals. So thank you very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.